Malignant ascites is a common complication of advanced intra-abdominal and gynecologic malignancies. Patients often suffer from abdominal distension, pain, early satiety, dyspnea, and reduced quality of life. The goal of this procedure is safe, long-term drainage, symptom relief, and improved patient comfort, typically performed under ultrasound guidance to minimize complications. The key point during ultrasound assessment is to identify the largest and safest fluid pocket to avoid bowel loops, liver, spleen, bladder, and abdominal wall vessels. Before starting the procedure, careful preparation is essential. Review imaging to confirm ascites volume and distribution, check coagulation profile if clinically indicated, and exclude sign of active infection at the abdominal wall. Indications for peritoneal catheter placement include recurrent malignant ascites that requires frequent paracentesis, poor functional status or limited life expectancy, palliative symptom control, and finally, failure or impracticality of repeated large volume paracentesis. After all this, the skin is cleaned with antiseptic solution and sterile drapes are applied. Adequate anesthesia should be performed to significantly improve patient tolerance and reduces movement during catheter placement. Equipment checklists are sterile probe coverant gel, local anesthetic like lidocaine, peritoneal drainage catheter kit, often tunneled or pigtail type, scalpel, dilator, guide wire if Seldinger technique is used, like in this patient, sterile drapes, gloves, and dressing materials. Now it is time to get access to peritoneal cavity. A needle is slowly advanced under continuous visualization and monitor. Entry into the acidic fluid is confirmed by free fluid aspiration that we can see here. Then a guide wire is inserted smoothly into the peritoneal cavity. The needle is removed while maintaining wire position. Once the tract is prepared, the peritoneal catheter is advanced over the guide wire into the abdominal cavity. You can obviously see the catheter in the cavity on the ultrasound monitor. After the placement of catheter, the guide wire is removed. We confirm the correct positioning of the catheter by seeing free fluid of the cavity. After placement, ascitic fluid drainage is started slowly. It is necessary to avoid rapid large volume drainage initially because it may cause hypotension, electrolyte imbalance, and renal dysfunction. Typically, 1 to 2 liters are drained initially, depending on patient tolerance and institutional protocol. Then the catheter is secured to the skin by using sutures or fixation devices. After the procedure, we cover the catheter site with a sterile dressing and inspect it for leakage or bleeding.